Okay, let's talk about geriatric syndromes. Geriatric syndromes are groups of specific signs and symptoms that occur more often in the elderly and can impact patient mortality and morbidity. So we have Americans living a lot longer. If we look back in history, in 1900, the average age of a man when he died was 48, 46, that of a woman, and now here we are with actually 4.2 million Americans over the age of 85. So we do live longer. The proportions of Americans are getting older, and that's because of the baby boomer generation, the huge influx of babies that were born after the Second World War are now old, and we have older people. So what do we see? Well, we see atypical presentations of signs and symptoms in older people. And we might just see it as a functional decline. There's some misleading signs and symptoms. And the signs of one disease process can be obscured by another. Often we're going to see people who have osteoporosis, hypertension, diabetes, and gout. And now all those different signs and symptoms obscure one another. There also could be no presentation at all. So the elderly do present differently. A third of the presentation will be related to their disease process. A third is related to disuse or inactivity. And a third is actually related to their aging itself. So what is the definition that we're going to use for geriatric syndrome? It's a broad categories of signs and symptoms common in the geriatric population. That's just what it is. It's a major focus for nursing research now and for guiding our best practices. And if we pay attention to geriatric syndromes and what we're seeing, we're going to have a bigger impact on the morbidity and mortality of our geriatric population. So, like I talked before, normal or contributing factors are the normal aging, multiple diagnosis, like I said, and then adverse effects of therapeutic interventions. Perhaps they are having side effects of medication they're on. Maybe they have too many medications. They have polypharmacy. They're on many meds that are counter-effective. Or there's another instance that we have as polyprovider, where they're going to a number of physicians or healthcare providers getting conflicting advice, and they're taking too much medication, and they're doing things that are counterproductive. So we have a great mnemonic for geriatric syndromes, SPICES with 2P, and that stands for sleep disorders, problems with eating or feeding, pain, incontinence, confusion, evidence of falls, and skin breakdown, and we're going to talk about each one of those things. Sleep disorders. Well, what's the etiology of that? It could be age-specific. The quantity of sleep in 24 hours remains unchanged with age. But we do see that there's more daytime naps, and the quality of sleep at night actually decreases. We'll see increased sleep in our geriatric population in stages 1 and 2, but there is a decrease or actual absence of stages 3 and 4 of sleep. And they're less tolerant to changes in their sleep-wake cycle. They're very, they do better with the routine of their regular sleep pattern. The environmental factors, noise could be a contributor, room temperature can disturb their sleep, uncomfortable mattress, those hospital beds, they're not comfortable. Bedfellow habits, if you have a partner that snores, your sleep is altered. And that's what my husband tells me anyway. And also it could be a strange environment, and we know this when we have patients that are admitted to the hospital, they have difficulty sleeping in that strange environment. There could be medication or adverse side effects. Now, antidepressant side effects may affect their sleep patterns. Caffeine definitely affects many people's sleep patterns. Analgesics and diuretics. We know if you take a diuretic late at night, you'll be running to the bathroom quite regularly. Disease processes or disease-related sleep problems, we can see that with heart failure, an overactive bladder, GERD, lying flat, they're going to get heartburn, COPD, lying flat, they're not going to be able to breathe, Restless leg syndrome will disturb sleep. Sleep apnea definitely will. Pain of arthritis or musculoskeletal pain, anxiety, depression, dementia, all those things have an effect on sleep. So, what are the results of sleep deprivation in the elderly? Well, if they don't get enough sleep, we're going to see forgetfulness, we'll see disorientation and confusion, there will be a cognitive impairment, we might see restlessness or wandering, and that can lead to falls. We may see depression, and sundowner syndrome is a known phenomenon where they're lucid throughout the daylight hours, and then when the sun goes down, these individuals become confused. And then also the use of over-the-counter sleep aids may actually have a counter effect of keeping them up. So what do we need to do is a sleep assessment. We need to determine patterns and rituals of bedtime, how the amount of sleep and nap time that's going on, if there's any use of prescription drugs or over-the-counter medications for sleep, or herbal preparations, are they taking anything like that? We need to determine their sleep environment and how often they need to use the bathroom during their sleep cycle. So what can we do as nurses to promote sleep? Well, we can have as normal sleep patterns as possible for those individuals. We need to time our medications appropriately. If they go to bed at 8 o'clock at night, it is inappropriate for us to go in at 9 o'clock or 10 o'clock and give them their meds. We need to adjust the pattern to them. We need to avoid any kind of stimulants before sleep. We need to have routine exercise for them, allow natural light, natural sundown, quiet environment at night. We need to use medications with caution and consider any side effects of the medications that are on as problematic to their sleep patterns, and evaluate and treat any medical problems first. Okay, problems with eating or feeding. Often the cause of the nutritional problem is the diagnosis itself. That's usually in 80% of the time. They could have some dietary limitations because of their diagnosis. They have shortness of breath with heart failure or COPD, perhaps pressure ulcers, cancer, something like that. Maybe they're eating poorly. That might be because they have poor food choices, or they don't have access to fresh fruits or vegetables, and they're using prepackaged, pre-prepared food. Perhaps they have a mechanical problem where they have tooth decay or oral pain, poor fitting dentures, maybe something's underneath their dentures. They have no dental care, they have oral disease, perhaps they have an economic hardship. We know that quite a few of our elders have a very low income and are below the poverty level. They have less money left for food and transportation to get that food. And we all know healthier food is more expensive. They may have reduced social contact. They live alone. 1/3 of our elders live alone. And perhaps mealtime is lonely, food's not interesting, they don't want to prepare it, and they're depressed even, and that can cause a decreased interest in eating. Maybe it's multiple medications. They have decreased appetite as a side effect of a med, or maybe a side effect of a med is dehydration, constipation, nausea, vomiting. We know that those are listed as side effects of many medications. And some meds actually do cause a decrease in nutrient absorption. Many medication will alter the dietary intake, and some patients actually get full when they take a glass of water with their medications, and it fills them up, but it's not nutrient supportive. Maybe there's some involuntary weight gain or weight loss, and their basic metabolic rate decreases with time, and with age we have an increased need for vitamin D, B6, calcium, fiber. We need more of those things. Maybe they need assistance with eating. Maybe they have trouble walking to get to the store to buy food. Maybe they have trouble with shopping. Perhaps they can't cook for themselves, or they can't feed themselves. And perhaps there's a sensory impairment. We all eat with our senses. We know a wonderful smell of wonderful food will increase our appetite, but perhaps they have a alteration in their smell and taste. Perhaps they have vision and hearing problems where they can't drive themselves to get food, or they can't cook, or they have some issue that way. Look for signs and symptoms of malnutrition. We would see pale skin and poor turgor of the skin. The eyes would be dull. There might be swollen lips or a dry, swollen red tongue. Look for extreme thinness, muscle wasting, and edema. Look for signs of dehydration. Orthostatic dehydration, decreased urine, dizziness. Are they confused? Their irritability. Those are also signs of dehydration. Let's see what else. Do they have signs of vitamin deficiency? Look at their oral cavity. Look at their eyes. Are there scleral changes? Look at their face, their skin. Is there flaking? Is there blotchiness? Is there cellophane-like tissue? Look all over their body. Do a complete nutritional assessment. Examine the mouth. Lab work we're going to look at albumin, H&H, B12, iron, transferrin levels. Look at their meds. What kind of meds are they on? Review any comorbidities. Find out what their usual weight is. Is there a change in the weight? What's their diet history? You want to do a dietary diary for about 5 to 7 days. Look for patterns. Look for preferences. Look for percentages of food being eaten. Determine the socioeconomic and cultural factors that these people have. And we're going to be using the mini nutritional assessment when we're in clinical. This is a great tool to keep with you throughout your career so you can do an assessment on your patients. And what will our interventions be for nutritional issues? Well, of course, we can consult dietitians. We can involve family and patient. We can use the community resources. The senior centers that you're going to be visiting in this class have a wonderful meal program, and I hope you all look at that meal program when you're out there visiting the senior centers. We want to prevent dehydration. We want to prevent food-drug interactions, so know what meds they're on and what food to avoid for those meds. Resolve any feeding or environmental problems, and consider appetite stimulants if necessary. Okay, so let's look at pain. There are some myths about pain in the elderly, that it's a normal part of aging, that they have a high pain tolerance, or that they complain a lot about pain. Those are not true. Let's talk about the truth. Pain can contribute to depression and anxiety. It decreases socialization, and it decreases functional ability. Those who have dementia or a cognitive impairment may not be able to actually express pain. Smaller doses of opiates may be needed due to a decrease in drug clearance and metabolism. So with the elderly, we have to be careful with our dosing. And they are very at risk for being undertreated for pain, just for that same reason. Pain treatment is a major element in improving the quality of living for our elderly, and we have to consider the chronic pain that they have and how it's treated when we're treating acute pain. So when we're in the hospital treating a patient for an acute episode, we need to consider what they have going on chronically and what kind of chronic pain that they may be in. So when we recognize pain in the elderly, we're going to look for sources of pain, behavioral responses, as well as the parasympathetic and sympathetic responses that we can see. When we're treating pain in the elderly, we want to talk about medications to avoid. There is a list that was put out by Beers, and that's spelled BEER''S, criteria, and there's 48 drugs on that list to avoid or use cautiously with the elderly. On that list is meperidine, that's Demerol, propoxyphene, mixing of agonist antagonist analgesics with agonist analgesics. And NSAIDs are also to be used cautiously. So we do use for analgesia in the elderly, we use acetaminophen, Tylenol is used, methadone, we use fentanyl patches, and lidocaine patches and gel. Other meds that we use adjunctively with for pain could be antiemetics, antihistamines, phenothiazine, steroid, capsaicin, Neurontin, antidepressants, SSRIs, and we want to consider also the non-pharmacological pain relief methods we can use, such as hot and cold. So the principles of pain management in the elderly is we always ask about pain. That pain is what the patient reports it is. It has a huge impact on quality of life. We want to determine the cause of pain, but treat even if we can't determine what the cause of pain is. We want to use drug and non-drug therapies. We want to consider costs for our limited income individuals, well, for everyone. We want to consider the side and adverse effects of drug-drug and drug-food interactions. We want to treat depression, anxiety. We want to address any dependence, addiction, tolerance that has occurred. And we want to evaluate a treatment plan regularly and keep everyone involved. Let's talk about incontinence. This impacts quality of life physically, psychologically, socially, domestically. It can be occupationally and sexually. A great deal of money is spent annually on incontinence products, treatment, workup, etc. And let's look at the type of urinary incontinence that we're going to see. Urge, which is due to detrusor irritability and abnormal bladder contraction. There's stress incontinence, which is due to reduced sphincter resistance and a sudden increase abdominal pressure. They can have stress incontinence from that. Overflow is due to overdistension of the bladder that exceeds the outlet resistance, so it just blows out. And then functional, it's either because there is a physical or a psychological inability to reach toileting facilities. So what are the causes? Well, many. The patient could be impacted. They could be constipated. The pelvic floor muscles are lax. Diabetes could cause it. Spinal cord injury. Delirium, depression, neurological problems. Poor mobility. They can't get there. They have an infection. Vaginitis, urethritis, prostate problems. Too much fluid intake, too much alcohol, too much caffeine. Maybe they had some gynecological or urological or gastrointestinal surgery that causes this. So we also want to see what medications they're on. Are they on anticholinergics? Are they on diuretics? Are they on narcotics? So what kind of questions do we ask our patients? Well, we talk to them about frequency, urgency, burning. Do you have those things? When you sneeze or cough, do you wet your pants? How often do you get up at night? Do you limit your fluids or hold your diuretics ever? Do you dribble when getting to the bathroom? Do you plan your life around going to the bathroom? And do you wear a pad? So there's some behavior modification methods that we can teach our elderly. Pelvic floor muscles, those are the Kegels. Try and relax the rest of your body. Concentrate on suppressing urge. Wait till the urge subsides. Walk to the bathroom at a normal pace. We don't want any falls. We want to adjust their daily fluid intake. We want to reduce nighttime fluids. Eliminate any bladder irritants such as caffeine or alcohol, nicotine. Prevent constipation because that can definitely have an effect on the urinary incontinence. Time adjust the meds. Treat infections. If it's environmental, we want to improve or arrange those conditions so that the patient can get to the bathroom. There might be bladder and habit retraining. and in some cases we're going to be teaching intermittent catheterizations and, as a last result, absorbent pads or briefs for our adults. There's medical procedures that could be done, surgery, collagen injections, clamping, pessary, all sorts of things. And then meds that we will see used for that are anticholinergics, antidepressants, alpha agonist agents for stress incontinence. There's vaginal creams and sleep meds as well. Fecal incontinence. It affects between 2 and 7% of adults and 45% of the adults that live in long-term care facilities. It's associated with an increase in mortality. And 2/3 of individuals who have fecal incontinence will not talk it over with their healthcare provider. So what happens? How come they get that? What causes it? Well, there might be a decrease in mental function. There might be actual physical disease. There might be a side effect of a medication. What does that? Quinidine, antibiotics, magnesium-containing antacids will cause fecal incontinence. Levodopa, theophylline, NSAIDs, lactulose, sorbitol, and sugar-free foods. So what do you want to ask your patients? You need to ask them, how many BMs do you have a day? Do you have trouble with your bowels? What do you use to help your bowels? Do you ever not make it to the bathroom or wear a protective undergarment? And what type of toilet facilities do you have? So we want to treat fecal incontinence by identifying the cause, get a great H&P, modify their environment, modify their diet, evaluate and change their medications if that is the cause factor, decrease stool frequency, improve this consistency through diet, and bowel retraining or surgery if necessary. Okay, so let's talk about confusion, which includes delirium, depression, and dementia. Dementia, first of all, defined as organic mental disorder with slow loss of intellectual abilities that interfere with functioning. So what do we see? What characteristics do we see? Well, we see aphasia, apraxia, agnosia. We see a decreased intellectual function, changes in personality, loss of short-term memory to begin with and long-term memory later. They will lose inability to recognize people. And this is usually uncovered or worsened by the stress of a hospitalization. So when we have our individuals come in who are kind of borderline on this dementia, it will worsen during hospitalization. And they are at increased risk for delirium. The behaviors that we see for those with dementia are paranoia, delusions, illusions, hallucinations, wandering, insomnia, undressing themselves. They could be incontinent. Like I said before, they'll have an increased risk for delirium. They might harm themselves or others. They yell, they scream, continually asking of questions, and perhaps have inappropriate sexual behavior. So the actual cause of dementia can be disease process like Alzheimer's. It could be vasculature with multi-infarcts. We could have a brain tumor, AIDS, Huntington's disease, Parkinson's disease. They could have a deficiency in B12 or folate. There could be long-term alcohol abuse, hypothyroidism, untreated syphilis, of course, and then a chronic liver or kidney disease can lead to dementia as well. So we assess these individuals with a history and physical. We do appropriate diagnostic exams, and we do the mini mental status exam, another tool that you're going to be using clinical. So you're going to get to use that one as well. Treat dementia by finding and identifying the cause and treat any cause if we can. We want to avoid any anticholinergic agents and antipsychotic agents. We will use. We may use hormone therapy, and we will also use, primarily for Alzheimer's patients, Aricept, Namdia, Frimil, those type of drugs. So let's talk about delirium and what it is defined as: the reversible, abrupt impairment of global cognitive impairment. And the characteristics we see with someone with delirium include acute confused state and encephalopathy. They have an altered mental state, and this happens with 25% of our elderly. 65% of post-operative elderly that are greater than 70 years old will have delirium, and it's increased risk for death or poor outcome for those who do have delirium. The causes, and I like this little acronym, it spells out delirium. So D is for drug use, E is electrolyte imbalance, L is lack of drugs, withdrawal or pain, I, infection, R, reduced sensory input, I, intracranial effects, U, urinary incontinence or fecal impaction, M, myocardial infarction. So we use the confusion assessment method, another tool you're going to be using, as a diagnostic algorithm. And we treat delirium by finding the cause and treating the cause, and then use medication for the behavior that is problematic. Finally, depression, the other D in the 3 Ds. 10 to 15% of the elderly are depressed, and 43 of those percent of the elderly who are in acute care are depressed. And here's the big one: 75% of the patients in long-term care facilities are depressed. 3/4 of the patients or residents in long-term care facility are depressed. It's sad. Signs and symptoms. They're vegetative. We can see psychological as well. And the behaviors, we see change in their sleep, their interests, in their activities around them decreases. They have guilt or remorse. Their energy is decreased. They have problems concentrating. They have change in their appetite. And they have psychomotor agitation, or actually retardation of their psychomotor skills. They lose them. And they may have suicidal thoughts. So we want to check by assessing through a geriatric depression scale. We want to evaluate suicidal risk, evaluate physical causes, and use any medical cause, is there a medication cause or a treatment cause for this? Evidence of falls. Statistically, 25% of the falls occur over 70 years of age. 35% of falls are those who are over 75, and 85% of falls occur in the home. Injury rate in hospitals from falls can be 10 to 25%. That's too high. 10% of fatal falls involve stairs, and 15 to 33% of falls in elderly result in injury. And you can read further of all these interesting percentages of falls statistics. So who falls? Well, active elders fall more because they're active. They get up, they move around, they're getting up, down, they fall. But frail elders have more repeated falls. So what contributes to these falls? Medications, big culprit. Sensory deficits, physical limitations, cognitive problems, and environmental traps. So we want to assess for fall risks. There's a couple of tests. There is the Hendrick 2 fall risk model and the Get Up and Go test. So you can read up on those if you'd like to know more about them. So what we want to do as healthcare providers is to prevent falls. And we do that by helping the individual incorporate lifestyle changes, perhaps use physical and occupational therapy assistance for those changes. To fall-proof the environment, home health nurse goes in and does an assessment for that and evaluate their medications. Skin breakdown. Statistics are there for you. It affects 1 million adults. It is present in up to 10% of all those who are in healthcare settings. All those, not just the elderly, all of those. And mortality with breakdown is up to 40%. Each ulcer costs $15,000 per ulcer, which can give us an annual cost in the United States of $1.5 billion per year for skin breakdown. That is not good. So, pressure ulcers are big on our radar screen. They can add 16 days to a hospital stay. There's pain, definitely associated with them in stage 2 or greater. It's associated with osteomyelitis, cellulitis, abscesses, sepsis, and it definitely increases the mortality and morbidity of our patients. So we do need to look at pressure ulcers. There's an article you've been assigned to read about pressure ulcers. We need to know the difference between stage 1 through stage 4. The Braden Risk Assessment, we're all very familiar with it. Read it. Have a look at it. Plant it in there. We want to prevent skin breakdown. We want to treat skin breakdown and get involved. Most facilities have a specialist in acute care settings. It's the wound nurse that comes in and does a lot of the skin assessments. But it is our role as healthcare providers and hands-on providers to make sure that there's no skin breakdown by using appropriate nursing intervention.